Assalamu alaikum everyone. Today we are going to discuss very important topic, that is rheumatic heart disease. Rheumatic heart disease occurs as a result of rheumatic fever. It is very surprising to know that simple pharyngeal infection or simple sore throat, if untreated, can cause damage to the valves of heart or even can cause death of the patient. So, what is rheumatic fever? It is immune mediated inflammatory disorder which occurs as a result of group A streptococcal pharyngeal infection. The most commonly involved bacteria are Streptococcus pyogenes. It is multi-system disorder which involves the heart, brain, joints, skin, and the subcutaneous tissues. The most commonly involved age group is 5 to 15 years of age, and it is type 2 hypersensitivity reaction. Let's talk about its pathophysiology first. When there is an infection of pharynx by the Streptococcus pyogenes bacteria, after 1 to 3 weeks of development of pharyngeal infection or pharyngitis, the cell mediated or humoral immune mediated response is generated. That as a result, the antibodies are formed against the antigens of these Streptococcus pyogenes bacteria, but unlikely these antibodies cross reacts with the normal tissues of the body like brain, heart, skin and subcutaneous tissues, and large joints of the body. When these antibodies cross reacts with the sarcolemma membrane of the myocardium as well as the myosin filament of the myocardium, then due to inflammatory process there is damage to the myocardium occurs. The SCOF bodies is a pathognomic clinical histological feature of the myocarditis in rheumatic heart diseases. This is basically a multinucleated giant cell surrounded by the collar of T lymphocytes and the macrophages because of immune mediated damage to the myocardium. Now come to the clinical features of rheumatic fever. The non-specific clinical features includes fever, anorexia, lethargy, malaise along with the arthritis. This is basically a initial presentation of the patient in the OPD or in the emergency department. So come to the major clinical features of rheumatic fever, that is arthritis, carditis, skin lesions and Sydenham's chorea. So the arthritis in the rheumatic fever is basically acute asymmetrical painful joints. It is migratory inflammation. That, for example, it starts in the knee joints, then suddenly shift to the elbow joint. The most commonly involved joints are knee joint, elbow, wrist, and ankle joints. That is large joints of the body. The joints become red, swollen, and tender, and it is most common acute presentation. Suppose we are going to if a 14-year-old boy with fever, anorexia, lethargy, and malaise, and have previous history of sore throat along with tender and painful joints, then you must think about rheumatic fever. The other clinical features are carditis, that is, carditis features includes pancarditis, that is, whole pericardium and endocardium and myocardium is affected. So, this is pancarditis. The clinical features or signs are dyspnea, that is, shortness of breath. This SOB or dyspnea is because of pulmonary congestion due to the left sided heart failure, chest pain and pericardial rub because of pericarditis, mitral regurgitation, mitral stenosis. The most commonly involved valve which is damaged in rheumatic heart disease is mitral valve. In acute cases, mitral regurgitation occur, and in very chronic cases, mitral stenosis due to calcification and fibrosis. Mitral stenosis occurs in chronic cases of rheumatic heart diseases. The other clinical features are aortic regurgitation, but the most commonly involved valve is mitral valve, and the second most commonly involved valve is aortic valve. And there is Carey Combs murmur. Basically, it is mid diastolic murmur which is due to the mitral stenosis, and also there may be a pansystolic murmur due to this mitral regurgitation. Remember, the important point here is that in acute cases of rheumatic heart diseases, mitral regurgitation occur, and in chronic cases of mitral in the chronic cases of rheumatic heart disease, mitral stenosis occurs. And there may be a syncope. This syncope is because of conduction defect or AV nodal blocks in the heart, and there is decreased blood supply to the brain. So syncope occurs in AV nodal blocks. So now come to the skin lesions, which may be a erythema marginatum and also subcutaneous skin nodules. These skin lesions are less common and occurs in less than 5% of the cases. So what is erythema marginatum? As the name indicates that erythema means red and marginatum means margin. Suppose this is the erythema marginatum. So the margins here are red and the center area is pale. These erythema marginatum usually affects the trunk and the upper extremities but not the face. And the other features is subcutaneous nodules. These are painless nodules on the extensor surfaces of bone and the tendon. Now come to the next clinical feature which occur at least 3 months after the development of pharyngeal infection. This is Sydenham's chorea, or also called Sedvitis dance. It is more common in females, and the first clinical feature in Sydenham's chorea is emotional changes, that is emotional liability, and then there is purposeless involuntary movements of hand, feet and face. So this is chorea. And there may be a halting and explosive speech, and spontaneous recovery occurs in these cases. So there is no need of any treatment, but symptomatic relief can be given by the treatment. Now come to the investigations of rheumatic fever. There is a Jones criteria for its diagnosis. There are few major criteria and some minor criteria. The major criteria, as we have discussed previously, that carditis, chorea, subcutaneous nodules, arthritis and erythema marginatum. These all are major criteria, and the minor criteria are fever, arthralgia, raised ESR and raised C-reactive proteins. Both these are inflammatory markers, and there is previous history of rheumatic fever with leukocytosis, that is increased WBC count, or first or second degree AV nodal block. So these are minor criteria. And the other essential criteria is evidence of streptococcal infection or scarlet fever with raised ASO titer and positive throat culture. These are essential criteria. If the patient has two major criteria positive along with the essential criteria, then it is diagnostic that this patient has rheumatic fever. And if the patient has one major and two minor criteria along with the essential criteria, then this is also diagnostic criteria for the diagnosis of rheumatic fever. Now come to the investigations. The CBC shows increased WBC count, that is leukocytosis because of infection, and there is raised or increased ESR, that is erythrocyte sedimentation rate, and raised C-reactive protein. These two are inflammatory markers as we have discussed previously, and the progress of the disease can be assessed by ESR and C-reactive protein. Throat swab culture is also indication is throat swab culture. It is positive in 10 to 25% of the cases because of late presentation of patients, and there is important test is ASO titer, that is anti-streptolizin O antibody titer, and it is in adults if it is more than 200 units, it is diagnostic, and in adolescent if it is more than 300 units in the children, then it is positive. So this is for adults, and the next is for children. This is criteria for diagnosis. The next important investigations are chest x-ray, which shows the features of heart failure like cardiomegaly and pulmonary congestion in severe cases of rheumatic fever. And the other investigations includes echocardiogram, which shows the mitral regurgitation in acute cases, and in chronic cases mitral stenosis and sometimes aortic regurgitation, and also shows cardiac dilatation. ECG shows gives the non-specific findings like pericarditis. There is diffused enlargement, diffuse ST segment elevation in whole leads of the ECG in case of pericarditis, and also there may be prolonged PR interval because of AV nodal blocks. So the ECG gives the findings of AV nodal blocks and the findings of pericarditis. So this was whole about the investigations. Now come to last but not least the management of the rheumatic heart disease or rheumatic fever. Bed rest is very important in these patients as it lessens the joints pain and also reduces the cardiac workload. So also strenuous exercise should be avoided in these patients if the patient has the features of carditis, and this bed rest should be continued until the ESR becomes normal in these patients. Now come to the next management step, that is treatment of heart failure. Medical treatment is important at the initial stages like ACE inhibitors, angiotensin receptor blockers, and beta blockers, and in severe cases, spironolactone, which is basically aldosterone antagonist, and in severe cases, valve replacement by surgery is needed. So this is management of heart failure. In the acute attacks, attacks of the rheumatic fever, a single dose of benzathine benzyl penicillin of 1.2 units million units intramuscular single dose is important drug of choice. Or if the intramuscular injections are not available, then the second option is phenoxymethyl penicillin 250 mg four times daily per oral. So this drug should be given orally if intramuscular drug is not available. And if the patient has allergy to the penicillin, then the alternative options are give the patient erythromycin or cephalosporin. The next treatment option is aspirin. As we know that aspirin has anti-inflammatory properties. So if the patient has initial presentation with arthritis, then aspirin is very useful drug. It reduces the symptoms of arthritis very rapidly within the 24 hours of the presentation. The dose for the aspirin is 100 mg per kg per day. 100 mg per kg. This is dose, and the maximum dose should be not more than 8 gram per day. So less than 8 gram is the dose. The side effects of the aspirin are nausea, vomiting, tinnitus and deafness, and also tachypnea and acidosis. And this aspirin should be continued until the ESR becomes normal. If aspirin is not working, then glucocorticoid in very severe cases is the next option, especially the prednisolone. The dose for the prednisolone is 1 to 2 mg per kg per day. This is dose for the glucocorticoid. And if the patient has arthritis along with carditis, then glucocorticoids must be given to these patients until the ESR becomes normal. The secondary prevention or secondary prophylaxis involved to prevent the recurrence of rheumatic fever: benzathine benzyl penicillin 1.2 million units intramuscular monthly. Or if the intramuscular drug is not available, then phenoxymethyl penicillin 250 mg two times daily should be given. But if the patient is allergic to penicillin, the next options are sulfadiazine or erythromycin. So this was whole about rheumatic heart disease or rheumatic fever. Thank you so much for watching this video.